Thank you, everyone, for joining. I'm sure people will keep joining as I welcome you all. And I'm letting everybody know that the workshop will be recorded, except for the breakout session. If you have an issue with that, please let me know via email. Make sure you're signed in if you're getting in for CE credit. Here's the registration phone number. And I am going to let Matt talk about how you get your connection and texting. Matt, you want to unmute and tell us?
Good afternoon. Can everyone hear me?
Yes.
Wonderful. Thank you all so much for joining. It's a privilege to be partially hosting and accrediting this course. My name is Matthew Stern. I'm the program manager for continuing medical education here at Children's Colorado. Once again, thank you so much for joining. Just a quick explanation of kind of the process you're about to go through. The first step is signing in for the conference. You've all been to a million conferences. You've all walked up to a registration desk 1,000 times and grabbed a pen and signed in. That is all done via text message now. Or in the chat, there is a link to a page that will also allow you to sign in. The only thing you can do on that page is type in the 6-digit code that you see on your screen. If you're going to be texting, that phone number that you see on your screen is our Children's Hospital Colorado registration phone number. That will never change. If you attend any conference accredited by Children's Hospital Colorado, you will use this phone number. You enter that phone number in a text message, and then you send that 6-digit code, ZUDZOG, to that phone number. That is all you have to do. You will get one of 4 responses, and if it says your attendance has been recorded, everything is great. If not, it's going to ask you to do something else in your profile. Perhaps you didn't add your phone number. Perhaps you entered the wrong number, but there might be more to do. Any questions on that, please find me in the chat or via email. There is an email from me in your inbox if you're in this call. That 6-digit code and this process will remain open for 1 week. Then once you do that, about 15 minutes later, an email will hit your inbox with a direct link to the course evaluation. That evaluation is your ticket to CE credit. We are a evaluation for credit institution. So please, not only do we care about that for credit, but we use that data in that evaluation. So even if you don't need the credit, please text in, get that email, and fill out the evaluation for us. This is going to help us build stronger programming and really show how well we did today. Like I said, I'll be on the call for the next 2 hours, either in the chat or via email. Please feel free to reach out if you have any questions. And again, we are honored to be a part of this. And back to Suzanne. Thank you.
Thanks, Matt. Please make sure you're muted at all times except when you go into the breakout room. And if you have any questions, please put them into the chat. In order to receive your certificate of attendance, you have to complete the online conference evaluation, like Matt said. And this is our schedule for today. You probably have received something like this in your packet. We have a little bit of change to the whole event, but I don't think that's going to be an issue. I'm Suzanne Edison. I'm the mental health coordinator at CureJM Foundation, and we are helping to sponsor this conference. Thank you all for coming. I'm going to introduce Dr. Tala El-Tal in just a minute. And now Dr. Tala El-Tal is currently a clinical lupus research fellow, and she's a recipient of the Jeff Carr Fellowship Award. She completed her pediatric rheumatology fellowship at the Hospital for Sick Children, Sick Kids in Toronto in Canada of June 2021. And she has a strong interest in mental health and quality improvement and patient safety. She and Dr. Andrea Knight, who is a pediatric rheumatologist at the Hospital for Sick Children, also in Toronto, who is also an associate scientist in the neurosciences and mental health program at Sick Kids Research Institute, and an associate professor of pediatrics at the University of Toronto, Temerity Faculty of Medicine. Both of these women and doctors are helping to organize this conference today. And I'm going to turn it over to Tala, and I'll do a little more introductions for each person when they join.
Thank you, Suzanne, and for that nice introduction. And first off, I'm so excited to see such a big group of participants here today from different parts of the world and making mental health a priority and highlighting the importance of really recognizing mental health challenge. So we'll actually start off with a few questions on this website called Menti that I'll be using. And this will really just help us to get a sense of where we stand as a group in regards to mental health. So I did put the link first thing in the chat of the Menti link right there. So if you click on that, you'll just wait for further instructions. And I will also share my screen where you can scan the QR code and that with your phone, so you can answer the questions from there as well. Here we go. So once we're all settled in and logged in, I can go ahead and move on to the first question. I'll give you a minute there. Lots of hearts that are sent to this is great. I could see that. And please, if you're having troubles with the link, just let us know in the chat. And Matt, if I could have you also moderate just the chat for this part, would be great. So I'm just going to log on to the first question and give people a little bit of time here. So the question is, I think it's important for a rheumatology clinic to screen patients for depression and anxiety. Give people a few more seconds. So far,
oh, I'm sorry. Yeah.
and if I could have all the speakers, sorry, or everyone who's on the call to mute, if they're not speaking, it'd be great. So just a few more, we're at 32 participants, 34, okay. So as you can see that a lot of us on the call here strongly agree in general that mental health screening or mental health assessment in rheumatology clinic is becoming more and more important and recognized as something key to do, and just wonderful to see that. Okay, so I'm going to move on to the next question. So when it comes to speaking with patients about their mental health, what worries me the most? So this is where I can have you just type in or on your phones or on your laptops some key words or subjects that you feel kind of worries you when it comes to speaking with patients about mental health. So I could definitely, I'll read out a few comments here. So lots coming in, some time constraints, appropriate follow-up, not having sufficient resources, again, very recurrent theme here, mental health specialists to refer to, again, resources coming up, timely support to offer, especially when obviously they're flagged that they need help, the lack of time, that they will take the question in the wrong way, not enough resources, again, lack of resources, safety planning is an important part as well, resources. So as you can see, there's common themes here of certain worries and I would say barriers to mental health screening for sure. I'll move on to the next question, just given the time breaks, and thank you for participating, putting those answers. So today I'm hoping to learn about, so we'd like to know what are some things or topics that we'd like to learn about from this session and the future sessions as well. So you can also type in just some key topics or terms that you'd like to learn about. Best approach for assessing for depression, anxiety, quick screening tools, tips and tricks for screening, practical strategies, again, screening and resources, easy screening tools, best practices, tips and tricks, realistic and helpful skills, quickly assessing severity of anxiety and depression, resources, perhaps to refer patients without needing social worker, screening and quick interventions regarding mental health. Again, very, very common themes here. And it's so interesting to see that everyone's, again, encountering similar barriers as well as similar things that they'd like to learn about in terms of tips and tricks and hopefully practical ones. And we'll be able to provide you with those tools today for this workshop. Perfect. So I'm going to move on to the next question. Identifying mental health symptoms is important in youth with rheumatic disease because studies have shown that they are associated with the following: poor medication adherence, option A, poor health-related quality of life, low physician global assessment scores, increased pain and disability, or all of the above. So what option you think is the correct answer? And I could definitely see that all of us, not going to give the answer away, but as you could see, all of us are choosing the all of the above option, and that's correct. So identifying these symptoms and treating these symptoms early on is really important because they are known to be associated with these poor outcomes that have been cited repeatedly in the literature. So I'm really happy to see that we're all aware of this. So I'm going to go on with the next question here. So mental health screening, so the term in terms of screening entails, one, is it using brief and clinically validated measures during medical care to detect mental health symptoms? Or B, using brief and clinically validated measures during medical care to diagnose mental health disorders? Or C, a questionnaire used by patients only in assessing for symptoms of mental health disorders? Or D, a questionnaire used by health care providers only in assessing for symptoms of mental health disorders? So definitely seeing lots of majority responding to the first option, using brief and clinically valid measures during medical care to detect mental health symptoms. And I'm going to give just a few more seconds, a few more time, a little bit of time just for others to answer, but I definitely see the majority choosing option one, which is the correct answer. So the key word is detect. And again, these screening tools are not used to diagnose. And Dr. Cave is going to go over some of those screening tools today. And these tools can be used by patients and as well as healthcare providers. So talking with caregivers and families about things in their life that cause them stress because of their child's health or care needs. Would you say that, so now we're gonna, for the next four questions, we want to assess how confident you are in clinic in talking about these subjects. So how confident would you say you are in tackling or essentially talking to patients, caregivers and families about things that cause stress? Okay, so moderately confident, with some minimally confident or very confident. So I'd say a lot of us are falling in the moderately confident group, but we'll get to see that if that changes essentially to the better, hopefully after these two workshops. Okay, I'm going to move on to the next question, just in the interest of time. So providing individual resources and guidance to improve the mental health and quality of life for patients. Again, rating your confidence from not at all confident to very confident. Where would you put yourself based off of the statement? Okay, so we have kind of diverse answers here. So minimally confident, about 46%, 35% saying moderately confident, and very confident, about 13%. So I feel majority of us are falling in the minimally to moderate groups as well. And in the next question, so providing individual resources and guidance to improve the mental health quality of life. So this time it's for caregivers and families and not just patients. So very similar to the previous question. Again, we're having some similar responses. Again, it's interesting to see that
Just
I think
time,
all
Tala.
of us are, sorry?
Just time.
Yes, of course. And then the last question is screening and making appropriate referral and follow-up for patient mental health concerns. So this is just the last question. We'd like to get a sense of where you fall in this category. We'll just give it 10 more seconds and then we'll cut this short. Perfect. Okay, thank you everyone for participating in this part. So I'm going to stop sharing my screen so we can go ahead. I'll give it back to you, Suzanne, to introduce
Andrea again. Thank you, Tala. Thank you, everybody, for participating. That's really going to be helpful as we move forward. So the next presentation will be by Dr. Andrea Knight. She'll be talking about the importance of mental health in pediatric rheumatology and its impact on patients and families. I gave you a brief introduction to Dr. Andrea Knight. I will also tell you that she is the founder and co-leader of the Mental Health Work Group for the Childhood Arthritis and Rheumatology Research Alliance, also known as CARA. She chairs the CARA Lupus Committee, and she's a member of CARA Diversity, Equity, and Inclusion Committee. I'd like to welcome Dr. Andrea Knight.
Thank you, Suzanne, and thanks everyone for joining. I'm just going to share my screen. Really exciting to see everybody here today, and just wanted to give a little bit of an introductory overview. And I titled this, it's a journey. It's not a one-time thing. This workshop is a result of several years of work of a lot of people. And we're really excited that you guys are joining us for the workshop and on the journey. So for this portion of the session, we're going to discuss the mental health impact for children with rheum disease and their families, and then also assess what are the opportunities that we have to improve their mental health care and really their overall care and outcomes.
Andrea, so sorry, we are seeing the presenter view with the two
Oh, you
slides.
are.
Yeah,
Okay.
so just wanted to give you a heads up on that.
Is that better?
Yeah, that's
Perfect.
sorted out.
Okay, thank you. And so I want to start off with this slide. I just want you guys to read silently for about 20 seconds. These are words of patients regarding their mental health. So go ahead. Okay. So I think, some of these quotes are really powerful, right? These are patients with physical conditions who are talking about the mental health impact. These slides are courtesy of one of our adolescent medicine doctors here at SickKids. So these are the words of pertaining to our own patients. This is a study that Kaveh Ardalan did, and he's on the call today, which is great, where we interviewed parents of patients, in this case with juvenile dermatomyositis, and we asked the parents to say, how would you describe the emotions that your own kids feel, kids with juvenile dermatomyositis? You see at the center here, this is a word cloud. So the size of the word represents how frequently the word was mentioned. So anxiety is front and center. You see depression a little bit lower down, anger, loneliness, isolation, so many encapsulations of how the patients are feeling. And we found this to be really powerful, touching all aspects of their lives, not just pertaining to their medical care. And from that same study, we also got a glimpse of how the parents perceive their own emotional struggles. So this is a quote from a father of a juvenile myositis patient. And he said, as a parent, you're dealing with emotional perspective of your child, and then as a parent, and then in the marriage relationship. So there's different dynamics that you have to be constantly aware of. How do I take care of my child? How do I take care of my wife? How do I take care of myself? Mentally, physically, emotionally. That's a lot to deal with from the parent's perspective. There's always that pressure. I think that there's the caring side, and there is the I've got to take care of business side. And how do I do that? And the pressure that comes to me. Another very powerful words from one of the parents. So I mentioned at the beginning that this really can be perceived, I think, best as a journey. So, we have these words and these experiences that we have with our patients in clinic, and these are the things that they may or may not tell us. But one of the things that is very helpful to try to improve mental health is to first define the problem, and then that helps us to develop and implement solutions. And I put up a map of the CARA sites here because, as Suzanne mentioned, a lot of this work has really been made possible by having our CARA mental health work group, which many of you have been a part of over the years. And so just as a testament to all of the work and the efforts that have gone into better understanding and in trying to improve mental health. So in terms of defining the problem, a lot of work has been done over the past several years, not just here in North America, but all over the world. to really establish that mental health problems are fairly common. So about 1 in 3 of our patients will have depression or anxiety symptoms, which may or may not develop into a full-fledged depression or anxiety disorder. This is generally thought to be higher rates than in healthy peers, although there are some conflicting studies. About 1 in 6 of our patients will have thoughts of suicide at some time. But really importantly, up to 75% really may not have had mental health evaluation and therefore really may not have had mental health access to mental health treatment. And when we think about it, there are many factors for adverse mental health. A lot of studies have looked at these various factors. Sort of going from left to right, we have the fact that our kids are under neurodevelopment. Their brain is under construction, particularly our adolescents, as many of us can attest to. But having the chronic rheumatological disease really conveys a lot of different things. So there's different limitations in different aspects: physical, social, academic, pain, there's stigma, there's the stress of managing a chronic disease, there's the uncertainty related to having chronic disease. Some of our chronic diseases, such as lupus, may have an aspect of brain inflammation. And then we have things that may not really be so disease specific, such as genetic and epigenetic factors, socio-demographic factors. And as many of us have seen, COVID-19 has really, really heightened the emotional stress of our patients. And what do we know about how mental health impacts outcomes? So as evidenced by the question that Kala asked, I think a lot of us recognize that there are a lot of impacts on the outcomes. There's a quote up here that's saying, you know, the serious impact on mental health, on physical health that mental health has. And this is associated with the prevalence, progression, and outcome of some of today's most pressing chronic diseases. And from research in our own patient population, we know that it affects many different areas, as you can see here, from adherence to healthcare utilization, to health-related quality of life, to transition, to educational attainment, and later work productivity.
It's 2-minute heads up.
Okay, thank you. So in terms of developing and implementing solutions, things that are being worked on, are mental health education for clinicians, which is right here today, and for patients and families, routine mental health screening, and tailored mental health interventions. So pertinent to today's workshop, we know that identification of mental health problems is the first step, as early identification and intervention, particularly for depression, can lead to less risk for major depressive disorder and suicide as adults. We know that there's recommendations for depression screening in youth from several bodies, including general pediatrics bodies, as well as disease specific bodies. But we know from our work related to the CARA mental health work group that a lot of the screening isn't happening. We had surveyed rheumatologists and behavioral health providers, and while many were in support, most were in support of routine screening, only 2% really reported that validated screening was in place, and the majority reported that there was inadequate symptom identification. And from that same survey of rheumatologists, we found that a major barrier was lack of education. But thankfully, most 91% were interested in being trained to evaluate mental health. And we're the appropriate people, I think, to assess mental health. Many of our patients consider us to be the primary caregiver. And when we surveyed patients in terms of their comfort in seeking mental health care with their concerns, the rheumatologists, by the bars extending most to the right, were found to be the providers which patients and parents felt the most comfortable. So we've made some strides with thinking about mental health screening in pediatric rheumatology, feasibility and acceptability studies, and also several quality improvement and implementation science efforts. And coming down the pipeline, we are working on some guidance statements and consensus statements, so stay tuned for that. We are also have several of our CARA members working on different types of interventions. So just to give you a sneak peek, Natasha Cunningham, who will be at this workshop, is working on a CBT intervention, which you will be hearing more about. And Suzanne Edison, who is co-hosting this workshop, has really illustrated the importance of partnership with patient foundations to really achieve our mental health care goals. So in summary, we know that mental health problems are very common in our children in pediatric rheumatology, and there's significant impact on their lives and their families' lives. Routine mental health screening really can lead to earlier detection and intervention of these mental health problems. And this is really a multidisciplinary effort, and you'll see this in terms of the speakers that we have here for the workshops. And also collaboration with our family partners is very essential. So lastly, really happy to say that we're making great progress on this journey, and I thank you all for attending. Thank you.
Thank you, Andrea. I know she had to go through those fairly quickly. Like I said, we are recording the session, so those will be available to you at a later date. Also, for those of you who've joined late and want to get CE credit, Matt Stern, who's from Colorado Children's, has put more information again in the chat. Right now, though, I'm going to introduce Sharon Lorber. She's going to talk about mental health bedside skills and how to start informal mental health discussions before screening. Sharon is a social worker and she's an interprofessional education specialist with the mental health portfolio at Sick Kids Hospital, and she's an adjunct lecturer at the University of Toronto's Factor Inwentash Faculty of Social Work. She has a social work background for nearly 20 years of experience working in child and youth mental health, and is currently part of a team developing a curriculum to enhance mental health literacy for hospital staff. Her other interests lie in the long-term impacts of childhood adversity and implementing a trauma-informed approach to healthcare settings. Please welcome Sharon.
Hi, everybody. Is my screen okay? You've got the right.
Yes, it's great. Perfect.
Okay, so what I'm hoping to do in this short time is just provide you with a bit of a toolkit for talking about mental health, having mental health conversations. I'm going to do a quick review of barriers and facilitators for discussing mental health, and then we'll go on to a guide for having mental health conversations. So it was interesting. I was watching the exercise that Tala did up front, and in terms of the barriers, they were quite all present that you mentioned, I think, other than burnout. So burnout in the literature is just kind of this idea that one more thing you want us to do, like we're already so burnt out, but I didn't see that show up, but the literature does talk about it. But then in terms of facilitators, you know, we also saw a little bit of that. The literature talks about buy-in, when there's buy-in. So this acknowledgement and knowledge that when we do treat the mental health conditions of our patients, we have better adherence to treatment, better quality of life, etc. We know that other facilitators is being part of a clinic that has a collaborative approach, so a multidisciplinary team, so that those concerns around who do I refer to, who's going to take on if a screen is positive, there's less weight on that physician per se, because there's more of a team approach. And
Sharon, can you sit as close to your computer as possible, because apparently your audio is cutting in and out?
Oh no.
Okay, that's better. That's better. Thank you.
And the other piece just revolves around training. So receiving training so that there's competence and confidence in addressing these needs. So I always like to start a talk that's talking about mental health and discussing mental health with this quote by Dr. Karen Treisman, who's a psychologist, from the UK. And she always says, you don't have to be a therapist to be therapeutic. And I couldn't agree more. I think it's all about creating an environment, a psychologically safe environment. And so, you know, we can create that type of environment with really focusing on the key elements of communication and then emotional contagion and emotional regulation. We're going to focus on the first for this talk, and if I can get the rest in around contagion and regulation, I'll try. So I like to start with just level setting about communication, and this may seem quite basic, but you know, communication is divided into verbal and nonverbal, and really so much emphasis is placed on the words we're using, when in fact, so much of communication is the nonverbal piece, the body language, the tone of voice. And I think we all just need that reminder of the importance of these. And so I'm going to use this guide. We created this at SickKids several years ago, an evidence-based guide to having compassionate communication, therapeutic communication, whatever you may call it, based on nonverbal and verbal skills. And I'm going to go through this in detail, but you'll see that most of these things are quite familiar. They're things that you probably know intuitively, but they're just delivered in 2 memorable mnemonics. So beginning on the left, we have tips to move the conversation. So that really talks about what to say. And then on the right, we have taking a soft approach, which addresses more of the nonverbal pieces. Okay, so starting with situational awareness. So borrowing from the aviation industry, and for those of you who are familiar with Caring Safely literature, so really this is referring to a thoughtful consideration of the context, the situation you're in when you're going to be having these mental health conversations. Is this a good time to have a conversation? Are you fully present? Are you being, do you have something that's really urgent that's coming up? Because you'll probably be multitasking or not being able to be present fully with that person. So just being mindful of the timing and the context of having these conversations. The other thing to be mindful about is the inherent power dynamics that exist in healthcare. We hold the power, even though we try to mitigate it, it's definitely there. And what are ways we can do to reduce it? So there was a study done several years ago by Kelly and colleagues looked at this. And she found they had physicians going to do rounds on their patients. And they asked these physicians to do rounds twice, one time standing up and one time sitting down. Deliver the exact same content and do it sitting versus standing. So what they found when they asked the patients afterwards, doctors who sat down at eye level were perceived as warmer and more caring. Patients had a better understanding of their condition, and the perception was that they spent 40% longer. So I like bringing this up because I think time constraints are always something that is brought up when we talk about mental health, and sitting versus standing is really not going to make a difference in terms of time, but it really does have an impact in terms of making patients feel more comfortable, feeling like you care more. So a better environment for discussing mental health issues. Next. So really looking at our stance, open posture is a powerful conveyor of whether you're approachable or not, whether your arms are crossed or not, whether you're leaning forward and engaged in conversation, whether you're nodding when someone's telling you the information. All of that conveys interest and warmth. Another tip is to even mirror the body language of the person you're talking to. And you can see if you're, at a restaurant, you see people that are on a first date, you'll often see that they're mirroring each other's body language, and you can see that date's going well. Another, sometimes I hear some feedback that if I'm too warm, I'm too empathic, it may kind of impact on my competence or perception of the competence or expertise that I have. Well, Kraft, Todd, and colleagues did a study back in 2017 where they had patients look at photos of physicians that were showing empathic, nonverbal body language versus unempathic body language. And then they measured empathy, warmth, and competence. And what they found was those physicians with the empathic nonverbals rated higher on everything. They're shown in the red bars versus the ones without the empathic body language are shown in blue, including competence. Next, we look at facial expression. So our face is really a roadmap to our feelings. And we know that facial expressions are universal across many cultures. It's important to really be mindful of what we're showing on our face when we're getting certain information disclosed to us. It may be shocking, and just to really not show a judgment. So just really kind of being conscious of our face. Also important to maintain that appropriate eye contact is important, and nodding. And then next, our tone of voice. So this idea of more important of what you're saying is how you're going to say it, of how it's going to land and the impact that it makes. And again, a study done showed that warm and supportive tone is preferred by patients and associated with patient satisfaction, perception of control, and adherence to treatment. So all good things. And then just a nice example of not what you say, but how you say it. So if you can think, if I had more time, I'd ask for volunteers for each of these, but how long have you felt this way? Whether it's an empathic tone, a judgmental tone, or an anxious tone, right? It lands quite differently. Okay, moving on to the other side in terms of what to say and how to move the conversation. It's interesting that the first element is pass the mic, which is really a reference to rather than talking and telling us everything you know and the education that you have and the advice that you have, it's actually more important to listen. You know, I think it's we're so used to giving advice, we're so used to fixing things, and a lot of times in mental health, it's not about fixing it. It's about listening and sitting there, holding really tough conversations and being in a room with difficult emotions, and just that's okay. Just allowing for that silence and really being present and listening. A study done about how long physicians wait before interrupting a patient. I'd take guesses, but just because of time constraints, 67% interrupt after 11 seconds. And I know I'm kind of picking on physicians during this talk, but it's healthcare providers in general. You know, we're all rushed, we are multitasking, we have a lot to do, but we know that waiting and really allowing patients to tell their story is very helpful to them. It's one of the top things that when you survey patients about what they appreciate, being, you know, having the time for the physician or healthcare provider to hear them out. Because really it's about connection versus correction. So what we want to do is we want to engage, we want to have that therapeutic relationship built. Once we have that, it's okay to kind of problem solve and give advice, but we really need to focus on that time upstream of building that connection. Just another a quote that I really like from the Zen master Thich Nhat Hanh about deep listening. And just how powerful that can be. Difficult at times to stay and listen during difficult conversations, but it's deeply therapeutic. So next we move to incorporating more open-ended questions, right? So those are the questions that can't be answered with a yes or no. They're really showing that you're curious, and they elicit more talking from the patient. The more a patient talks, the more they feel comfortable, the more trust they develop. And instead of feeling like they're just going through a checklist. So for instance, do you have any questions? Would change into what questions do you have? Are you doing okay? You good? How have you been doing? Again, stuff that we know, but it's always nice to have a reminder. Next is validation, and validation is probably your golden key. It's really the tool that's so helpful. I mean, I think that's like 80% of what I do when I'm talking to patients and families is validate their concerns. And what we're talking about is really this ability to acknowledge another person's feelings, thoughts, or wants without any judgment. Doesn't mean that we're agreeing with them, but it means that we hear them, and we're letting them know that we hear them. We know that validation communicates acceptance, and it lowers negative mood. It reduces emotional arousal. Actually, they've done functional MRI studies, and they've shown that the amygdala actually doesn't have as much activity when people are being validated. Okay, so let's look at an example of validating. I just want to be normal like all my friends. I'm so sick of remembering to take these medications. So we may say, it's very important for you to take your medications. You wouldn't want to have a flare, would you? But that's not validating. That's just, you know, dismissing and making her feel bad, most probably. So validation would look more like, yeah, it makes sense that you want to be like your friends and not have this extra responsibility. We can validate first, and then move on to problem solving and discussing options. So next question, I'm going to stop sharing my screen and we're going to put these up on Menti, and hopefully you'll have a chance to respond.
Yep, so I'm gonna just share my screen right now. So if you, I did put the link back in the chat. So right now I'm gonna have it for those who didn't log on to Menti before, but you could answer through there. So Sharon, you could see that a lot of responses are, that sounds stressful, I'm sorry.
Yeah, and I would agree. I would agree. I think, have you tried mindfulness is moving right into problem solving, which is not what we want to do. We don't want to just fix it right away. Don't worry, everything will be okay. It's placating. Everything may not be okay. But I agree with everybody there. I think validation is that third option.
Great, so I'm gonna move on to the next one.
Okay. So what do you mean you want me to leave the room? I need to know what's going on. And then the options are, just in case it's as small as it is for me, we have rules, and this one is one of them. Kindly step out. It must be hard to be separated from her, or we're trying to teach your daughter the skills to speak to providers on her own. Yeah, so I see the majority is going with the middle. It must be hard to be separated from her, which is validating, absolutely. And I think that once you do validate and have a little bit of discussion around that, you can move on to, we're trying to teach your daughter the skills to speak to providers on her own. To, then we can come back after validation and the emotional arousal is lowered. We can go on to problem solving and giving advice. Thank you.
Stop sharing my screen. You can go ahead and share your screen again, Sharon.
Okay. How's the time?
You had 2 minutes. 2 minutes. Yeah.
Okay.
It's on presenter view if you want to have it just as.
How do I switch it?
This bottom area underneath that big, yeah. Oh,
Oh, I don't want to waste
okay. Okay, let's go on.
It's okay. Yeah.
Where are we at? Empathy. Okay, so the idea is that we show empathy by doing all of the skills on this guide, right? By doing the whole move soft, you'll be able to be empathic. And then quickly, let me just go on to barriers of communication. So, we do want to stay positive, but really approaching things with a silver lining or looking on the bright side are not the best way. Again, it's a bit of minimizing people's trouble. So we do want to validate before we move on to any kind of just look on the bright side. We want to validate before moving on to problem solving. And we also don't want to give false reassurance that everything will be okay. I think we talked about that. I'm just going to skip over here into my final slide. Stop sharing. And just kind of maybe say, in terms of emotional contagion, what we're really referring to is that you're bringing energy into the room and the people that you're speaking to, you're picking up on their energy. And it's just this whole idea of, we impact each other. We're not siloed. There really is this bi-directional exchange. And it's easy to kind of get really taken in people's urgency, their anxiety, their low mood. And it's really important for us to ground ourselves before having these conversations on mental health, so we can be stronger and we can loan our nervous system so that kind of contagion can have a good effect. It was the last piece that I really just wanted to say. So thank you.
Thank you, Sharon. I really appreciate that. We're going to move on to Dr. Alana Goldstein-Lever is going to talk about identifying signs and symptoms of depression and anxiety. Again, if you have questions, please put them in the chat and we will save them for later or be able to ask as time goes on. Dr. Alana Lever is a pediatric psychologist at Nationwide Children's Hospital and is a clinical assistant professor at Ohio State University. Dr. Lever is the team psychologist for the Department of Rheumatology and Neuroimmunology Clinic within the Department of Neurology. She provides psychological services to children and adolescents with rheumatic diseases and neuroinflammatory disorders. Dr. Lever is also engaged in program development and clinical research focused on pediatric pain management and psychology integration within pediatric rheumatology care. Welcome, Alana.
Thank you. Thank you, Suzanne, for that warm introduction. Today, we're going to be discussing signs and symptoms of anxiety and depression. And we will dive right in. Here we go. I have no disclosures to share. And our objectives for this mini talk is to identify common factors among emotional disorders, which is what anxiety and depression are encapsulated under. We're also going to define and differentiate those symptoms of anxiety versus depression and review a couple of case examples to enhance our understanding. So, what are emotional disorders? We understand anxiety and depression to be under this umbrella, but really there's this shared aspect of negative emotions that our patients are dealing with. And we're going to talk about what that recipe is, how these disorders develop. And so we know that there's risk factors we'll discuss later on about a genetic predisposition or modeling that can happen within a family. But what we see for children and adolescents in terms of what they're experiencing is we have this first ingredient of negative emotions. So these are kids who are dealing with frequent and intense negative emotions. And in addition to having those negative emotions, because we all experience those from time to time, again, that frequency and intensity, it needs to be at a certain level that we'd qualify it. In addition to that first ingredient, we also tend to see a negative reaction to those emotions. So I'm feeling anxious and I'm finding that really aversive. That's very uncomfortable for me. There's a diminished sense of control in the situation or with the emotion in particular, that I don't feel like I can control this. It's out of control for me. Which of course is going to worsen the emotion. And then there's a negative appraisal. There is this view of the emotion as something that we can't handle or is not something that can be managed. Lastly, we see a behavioral component. So we see this behavioral avoidance developing of patients or youth or adolescents displaying efforts to avoid that emotional experience. That feels icky. I don't want to feel that. You know, kids will often share that with me, like, I don't want to deal with that. And so they'll avoid the situation. That's what we commonly see with anxiety is that, you know what, I'm really anxious in social situations, so I just prefer to stay home. And they kind of self-select in that way. Sometimes there is an attempt to actually proceed with the experience, and then we escape. With depression, what this avoidance looks like is more of a withdrawal. So a withdrawal from activities. But at its very core, this is avoidant coping. We're not actively dealing with this emotion and actively approaching the situations in our lives or the activities in our lives. So now we're going to differentiate a little bit and talk about the different types. So there are many different types of emotion disorders, but we're going to really focus in and narrow in on anxiety and depression, because those are more of our bread and butter of what we see every day. And you can also keep in mind that these are also emotional disorders listed here. So trauma disorders, somatic symptom disorders, and a lot of our patients in pediatric rheumatology, we do see that they have an active nervous system. You know, we see a lot of anxiety, we see a lot of chronic pain. And so when we speak about anxiety, I think you'll see a lot of parallels between what we see with chronic pain, because those often come together as well as with depression. But now we're going to go into more of a discussion of anxiety and what that looks like for patients. All right. Now, I'm sure y'all are seeing this every day, but these are the kids that are nervous and anxious. They might not appear in your visits. So this might be a patient that really is just fine talking to adults, but they're quite anxious with their peers. Or they might appear especially anxious in your visit. So I wouldn't anticipate that just because you're not seeing it in the room, it's not happening, but you might also very blatantly see it. It might be very present for you. Kids with anxiety often deal with some level of worry. There might be an increased awareness of that worry and an improved ability to report on worry. What we find for young children is the idea of a thought is harder for them to capture. And so they might not be able to reflect on that worry. And for other kids, they're very well able to. But with an anxiety disorder, we find that that worry can be difficult to control. Again, we already spoke to this, but we see that physiological arousal. We see that sympathetic nervous system activation or that fight or flight response going really, really getting on a high speed for these patients. So they might experience heart palpitations, rapid breathing. They might show more signs of cold hands. Their Raynaud's might be even more pronounced. So you will see this come up in different ways, but in its most intense presentation, they might report panic attacks, which is more of a time-limited state of physiological arousal, where we see within minutes, a patient reaches a peak of their nervous system response. So they're breathing heavy. They might have the sensation like they're going to die. It's a very scary experience patients recount on. And so these are some of the symptoms that you might see when you're looking for anxiety. Now, we already spoke to some other constellation of behaviors when we talked about emotional disorders. So we know patients with anxiety, they might show worry, which is more of that cognitive or thought element, but they might also show that behavior element of anxiety, that avoidance. They might not even be able to reflect that they're anxious, but they just feel uncomfortable in lots of different situations and avoid them. Oftentimes speaking to parents and kids is really helpful because the parent might be very well able to recount the avoidance that they're seeing in different situations. They might not be able to pin it to anxiety, but sometimes kids don't have a real good insight into the fact that it is anxiety. They just, well, I don't like that, so I don't do it. Well, if we dig in deeper, we can sometimes find that, well, that makes me really uncomfortable. I breathe really fast and my stomach hurts and I get really nauseous. And we know that those physical symptoms are also symptoms of the stress response. So I definitely focus on that mind-body connection. And I think for you as rheumatologists, you can really write on that as well, of how the mental health really relates to physical health and how those physical symptoms that our youth are experiencing might be very much connected with their mental health. In addition to that avoidance that we might see things more subtle. So if I'm avoiding the party entirely, then I am purely avoiding the situation. But I might go to the party and focus on my phone and just look down and text my other friends. That would be a safety behavior. I'm doing things to make me feel more safe in this situation. But if you see a teenager, on their phone, yes, they could just be disengaged patient, and we might assume that, but they might also be anxious and they might be trying to avoid that situation in the room because it's a hard discussion and it's too much for them in the moment. In addition to these primary symptoms we just described, I don't want y'all to be thrown off if you see irritability for patients with anxiety. So while irritability is a common symptom with depression, we often see it with anxiety as well. A lot of these kids with anxiety have such tension, have such arousal going on in their body all the time that they do develop more of an easy temper, or they're more quick to snap or have an attitude. And so I would be sensitive to that understanding that irritability might be a symptom of anxiety, and it certainly doesn't rule out that they don't also have depression. But what we do tend to see is anxiety and depression often roll together. In addition to that, we can see disruptions in health behaviors. So these are things that I think are commonly assessed for as sleep or school functioning in a rheumatology visit. And sleep we often see is very much linked with anxiety. We see delayed sleep onset, so kids going for hours not being able to fall asleep. They might just report that their mind is really busy. And that might be the case. There are some kids with ADHD who have trouble getting down to sleep, but a lot of times it's a harder thing to report that they're just racing with thoughts at night. In addition to that, we can see night awakenings. And in our teenagers, we just can have some poor sleep habits that develop as well. So we want to assess for that sleep because it might be that there's just some poor habits happening, or it might be that it's more indicative of anxiety. Concentration is also something that we see as a byproduct of anxiety being disrupted, because it's difficult to focus when you have these physical symptoms going on in your body, and your focus of your thoughts is really on these worries, these things you're concerned about. Now, what are the most common types that we'll see in clinical practice? So I've listed here from our DSM, which is our book of diagnostic classifications for psychiatric disorders, some of the most common disorders that we'll see. I did start with the most common that I see in my practice because I do work in pediatric rheumatology. So I would say generalized anxiety disorder is probably the most common type that I see in my practice. So this is just what it sounds like: generalized anxiety and worry. So these are the kids that are worried about all the things. They're worried about a number of different targets, and they often experience some of those additional symptoms we've just discussed. Physiological arousal, finding that their body is just tense. They're the wiggly kids who just are always moving and grooving, and it's really more of a product of their anxiety. They might show that anxiety interferes with mood or their concentration or sleep at night. Now, social anxiety disorder is also very much what it sounds like. This is more anxiety and avoidance of social situations. So these are kids that fear social and performance situations where they might be tasked with speaking to all of you today, or with getting up in front of their class for a presentation, or even being in front of people in any capacity. For panic disorder, this is similar to what I described for panic attacks, but what we see is more of a recurrent episodes of panic attacks and a lot of worries about this panic and changes in behavior because of it. Maybe avoiding situations because, hey, I had a panic attack there and I don't want to go back to that space. In addition to that, specific phobia is something that I do see a good deal of. So in my practice, what I commonly see is needle fears and phobia, or blood injection injury phobias. And hey, sometimes it's normative, really, expected needle fears, but I do see quite a bit of needle phobia just because our patients have increased exposure to pokes in their life. And with that, we just see intense anxiety around a phobic object. And with needles, it's specifically the needle situations or the procedures that they're undergoing. And then lastly, separation anxiety disorder, which again is much what it sounds like: fears about separation from a caregiver. So these are more of the common anxiety disorders that you'll see documented by mental health providers or just see in more common practice for youth and adolescents. Now we're going to transition over to depression and what that looks like clinically. So classically, what you probably think about with depression is sadness, more of a sad affect and a flat affect for patients. I also like to give a really good note that irritability is very commonly seen as a prominent symptom in adolescence. And so for a young adult or adolescent with depression, it might just be that they're very irritable. They might not have that sadness element. And so I wouldn't expect that someone has to be necessarily sad. That irritability can also satisfy that mood component. We might see a mix of both. In addition to that, these are the kids that are just really drained. Our patients are often dealing with comorbid disorders where they have a physical condition that drains them as well. But on top of that, their energy is also drained, not just by that, but their depression and all the school demands and the medication demands and the appointments they have to go to. I think we can all resonate with their fatigue, but part of that is also their depression at work. And that's something that we work a lot on educating them on, is really how to bank their energy and help them manage that energy level and fatigue. We might see increased tearfulness. Some kids with depression really shut down and become more numb. So we might see just less affect or less expression of emotion for kids when they're depressed. So it really varies. In addition to that, much like anxiety, we can see disruptions in sleep. I see kids with depression just needing hours and hours of sleep, far beyond what we recommend in terms of the aggregate and more expected sleep ranges. We can see also just difficulty sleeping, so that delayed sleep onset or just disrupted schedules. Kids with depression often don't have a good routine. They often don't have a good daily activity routine and schedule, which actually perpetuates more depression because they're not doing the things that are going to are going to prompt a positive mood and keep them more oriented and engaged in their daily life. Changes in appetite and eating. These kids might skip meals. They might be eating just a couple meals a day or a few snacks a day. And then reduce focus. So oftentimes I have patients report to me they're concerned about ADHD, but when I dive deeper, they've been depressed for 2 years and they've had no history of academic difficulty before then. And so first we need to address the depression because we know that these emotional disorders can have a big impact on concentration. And we need to see that we address that piece before we give a diagnosis of ADHD. We need to really dive into that emotional aspect of things.
2-minute heads up.
Oh, goodness. All right. So in addition to that, we see that reduced engagement in activities, more hopeless and guilty feelings, social isolation, and at its most intense, oftentimes thoughts of self-harm and suicide. Now, what are the risk factors? Adolescent age, personal or family history, experience with ACEs, major life changes or trauma, and then chronic illness, pain, and medications. A lot of our patients have all of these. So I thought it's pretty telling in what we're working with in terms of patients, how all of these meet a lot of the patients I see each day. In terms of observations that I want y'all to pay attention to is eye contact. If a patient is not making eye contact with you or the parent and seems really disengaged, that can be a sign. Speech and communication, if they're really shut down in the visit, they might be feeling anxious just in this visit, or this might be more of an enduring pattern. Adherence is something we oftentimes see can be impacted by anxiety and depression. With depression, we don't engage in our regular medication and routines because we don't care, or we just don't have the energy to do it. But with anxiety, we might just be avoiding it. And then finally, pain, flare, or a new diagnosis. These are going to tip us off for patients that, this is a patient that should be looked at because they're going through a lot and they're taking medications potentially like steroids that it can increase the likelihood of emotional symptoms as well. All right. So we'll probably have time for one case example. So we have Amy, who is a 16-year-old female, newly diagnosed with fibromyalgia and experiences widespread body pain. Amy relocated to a new school, but she's been skipping lunch because she doesn't know who to sit with and gets nervous about having to choose a table or having others watch her eat. She becomes easily embarrassed and often worries about saying the right thing. She dwells on these situations that happen socially and what she could have done differently. Amy often misses school because of her pain and her emotional distress. So I was wondering if you could write into the chat what you think might be going on with Amy, and even specifically if you can think of one of the specific disorders we talked about that might be a good, that might explain her behavior.
So I could read out some of these answers. Social anxiety.
Yes, please. Yes, nailed it. Okay, perfect. So we'll do one more and then I promise we'll wrap up. So Damon is a 15-year-old Black male with a history of arthritis. He has presented as irritable and unmotivated over the past few months since last visit. He has historically had many friends, but his mom's remarking on how he's been withdrawn and just not acting himself. He was previously an AB student, and now his grades have slipped to B's and C's. He's struggling to focus and getting a lot of sleep at night, but still falling asleep in class. He often forgets his meds due to oversleeping in the mornings, and he's just made statements that he just can't do the meds anymore. What do you think might be going on with Damon?
So depression is listed there. Depression, poor Damon, sounds like a common story. Depression.
Yeah.
Yeah.
You guys got it spot on. So I wanted to just reserve if there's any questions or things that, y'all were wanting to check in about before we finish up.
So there are some questions in the chat, but in the interest of time, I'm thinking, Alana, if you want to answer them, go ahead in the chat while we.
Oh, sure, absolutely. Thank you. That's a
great.
great idea. All right, I'm going to stop my share and we'll continue on.
Amazing.
Great. Thank
so
you,
much.
Alana. Yeah, there are some questions in the chat. I hope you can scroll around and look for them. Our next piece is going to take a little bit of time. I'm going to put you all into breakout rooms. These are some of the questions that you can address. If you'll give me some patience,
Sure.
I'm going to provide facilitators for the breakout rooms. I'm going to
So while you do
create.
that, I'm going to read the questions. So for the breakout room for everyone, the three kind of key discussion points we'd like you to go over is one, do you perform any mental health screening or assessment at your site? I would be interested to hear about that. And if so, what are some facilitators you've encountered, or the opposite, what gets in the way for you to do the screening? I know we've covered a bit of that in one of the initial questions asked, but in your small groups, we'd like to have that discussion, and then we'll have 1 point person from each group after about 9 minutes or 8 minutes or so to come back to the main group, and we'll all kind of share the key themes from each point person. And
I'm getting there. I'm getting there.
I will put
Okay,
the questions in
I'm
the
opening all rooms. Everybody, please click join. And we'll have 10 minutes in the room, and I'll give you a 1 minute warning. Okay, for anyone who is left here on my screen, can you hear me? I see Annie, Jennifer Weiss, Jim Minnow, Nadina Rubio, and Barbara. Yeah. Okay. So, Matt, somebody's on, needs to mute, maybe somebody in the background. Sorry. Thank you. Okay, so for the people who are in this room, some of the questions are, do you perform any, and you can unmute yourself if you're in the room with me. Do you perform any mental health screening assessment at your site? So there's Nadina and Jennifer. You're in this room with me. Or maybe you're not in this room with me anymore. Hello? Would you like to join a different room? Hello, Nadina or Jennifer Weiss? No. Okay. Nandini? Nandini, are you back? Unassigned. Who's unassigned? Nadini, are you here?
Hi, I have to go see my clinic patient, so I just popped back after I finished my clinic patient.
Okay, I thought that there might be two other people in this room. Nadina looks like she's on twice, and there was Jennifer Weiss. I don't know if you two are here, but you can unmute if you would like and talk. And if not, I'm just going to ask you questions. If you would prefer to answer them in the chat, feel free. Do you perform any mental health screening or assessment at your site? What are some facilitators you've encountered? And what are some of the barriers you've encountered? So how does it make it easier? And how might it be more difficult? And I'm not getting any response. So I'm assuming that people
can
are.
unmute and talk. This
Yeah.
is Nandini. I just rushed back from seeing a patient in clinic, but we have a behavioral sort of therapist in our clinic. So for some patients, so there is a form, and I'm going to pull up the form because I just had a patient fill it out. It's sort of like a mental health screening form. I'm going to tell you exactly what that is. But we don't do it for research purposes or anything. We just use it to see how they are doing in terms of their stress, mental health, and in terms of some of their other stuff. So we don't, rheumatology sadly doesn't have a social worker, but it does, it's a pediatric symptom checklist. That's what it is. It's a pediatric symptom checklist for age 13 and up. And then do you have any emotional, social, behavioral concerns that you may need help with? Would you like to see a behavioral consultant today? That's the lady we have who's overextended and trying to do what she can.
Okay. I have to do one thing first. Okay. All right, moved her. Okay. Does anyone, I don't know if there's anybody here who's going to respond, Nandini. So you have a psychologist in the clinic. Oh, Nadina has a psychologist in the clinic, she says. So I'm wondering if that's been helpful to you. Do you refer immediately to them? Do you talk to your patient first and then try to assess? Do you have a co-setup arrangement? That's a question to Nandina as well as Nandini. Okay, I'm not seeing any answers. Jennifer Weiss, are you on here? Or Janine? Janine is here?
Yeah, sorry, I was here earlier. I've just been having a lot of technical issues. I had to leave the session. I just come back, but I'm fine to just wait till everyone rejoins or whichever.
Okay, okay. Two people are unassigned. Do you want to wait here then in this room?
Yeah, I'm fine with that.
Okay. Nadina, do you have any answers about how you use the psychologist or physicologist? I think that's a psychologist, right, in your clinic? She says when we detect some anxiety symptoms, we talk to the parents and explain to them the need for a reference to a psychologist. Okay, that I understand that. What about to your patients? Do you talk to the patients about their own feelings and, noticing that, like, would you be saying to maybe a 10-year-old, I feel like, seems like you're feeling anxious or irritable or worried or any of those kinds of things? Are those the kinds of questions that you might be asking patients? And other people are welcome to answer as well. I have about a minute and a half left. Nandini says we use our behavioral consultant almost for every patient with rheumatic disease, compliance, anxiety issues, stress, etc. Are they in the room with you, or are you referring people out, Nandini?
I typically have them come in after I see them.
Uh-huh.
That's what I typically do.
there?
Or sometimes I bring them into the room if it's a patient with too many issues, with multiple very complex issues. So then I call our lovely consultant and ask her to just come in and join me.
Okay, so that's not standard. That would be after you've sort of assessed the situation.
Correct.
Okay. Nadina, where are you located? Are you in, I don't think you're in the US. I think you must be like Italy or Mexico or, you're in Mexico. Okay, yeah. So that's unusual to, is it more common that you would have a psychologist in the clinic? I thought that it's hard for us here in the US to get that. So is that something that you worked on to make happen? Were there any barriers to making that happen? You're welcome to unmute and talk out loud too if you want, or if English is harder for you and you'd rather type it, that's fine too. So Nadina, I was asking if that was common to have a therapist in your clinic, and was that something that you set up but to take some time? Just curious, you could put that in the chat. It would be wonderful to know. Welcome back, everyone. I think we'll do a really quick sort of readout of sort of answers to discussion. I'll start real quickly because we had a couple of people in the breakout room. Both of the people, one woman, one rheumatologist in Mexico. Nadina says that she has a psychologist in her clinic, works only for the rheumatology clinic, which is pretty fantastic. And also Nandini has a behavioral health person, and I think Nandini, you're in New Jersey, as I recall. And so she's able to call them in as needed. And both of them speak to both patients about, and they do talk to patients about their concerns. So that was our session.
I'll go next and just summarize some of the themes from our group. So time constraint is a big one. So sometimes 20 minutes are allocated for follow-ups or even less time, 40 minutes for news, and it's just really difficult to incorporate screening. So some centers are not able to, at least for now, to perform the mental health assessment. For the center that did perform mental health screening, I think one issue was what do you do with the positive screens? And then the next question is, how often should we be screening? So once they've been screened, do we screen them again and follow up? So that's kind of key. And also the follow-up piece of, making sure the resources are available for patients that are screened positive.
Another person, Andrea, would you like to go?
Okay, Elise, yeah.
Lisa's gonna.
You go. Well, okay, so Andrea asked me to report out real fast, so I'll just let you know, we had some really interesting models in our group too. Maria was telling us she's a psychologist for her rheumatology group, and she actually performs a more standardized mini kit as part of their transition clinic. So thought that was neat that they incorporated it with transition as well. And then Belina was telling us they don't necessarily have a specific one, but they have a specific insurance that will do some extra screenings for them. They're out in California, and then all of their inpatients do get like a head screening. And then Andrea told us that theirs, which I thought this was really cool too, because it's more accessible to all of us, is they do it as part of their kind of review systems and more casually. But then more recently, because of Tala and all her good work, they've implemented a more standardized screening as part of their lupus clinic. And we're starting to pilot one with us too. So we just got into kind of like what everyone's doing. We didn't get a chance to talk about the barriers and everything yet.
Great, thank you. Sharon.
Thank you. We talked a little bit, there's definitely an interest in doing it, but some of the barriers that we've already heard about, time, fitting it into the workflow, getting buy-in from the team. Another point that was mentioned by one of our participants is there's almost this questionnaire fatigue, because there's so many different questionnaires that are being filled out for rheumatological studies. So that's, I thought, was a really interesting point. Yeah.
Kaveh.
Yeah.
Thank you.
Yeah, pretty similar themes. So there was a range of experiences with screening. That there was, I think Jessica was sharing at Montefiore, they do some PHQ-9s and GAD-7s, but workflow can be tricky in a busy clinic, and sometimes you might even miss that there was a positive result waiting to be followed up. And I can relate to that. I've had that happen as well at our center. Lainey was sharing from Vanderbilt their experience with screening, piloting screening in a research context, and then eventually in an implementation science context in lupus, and some of the challenges and at the same time fruit that's been born from that. And then Layla was sharing a little bit about mental health education materials that are being developed for hospital-wide use at sick kids, with rheumatology as the Shining Star division that's going to pilot that, which is awesome. And then we definitely in terms of barriers, like a big one was where do you send patients who have positive screens? At least a couple of our centers, behavioral health groups actually will not even take new patients right now because they are so beyond capacity, and community partners are also at capacity. So trying to figure out like, so then what are novel avenues for care delivery, because the current system is just tapped out. So yeah, those are a few of the things that we discussed.
Thank you. Thank you. Megan, do you have a report?
I do. Yep. I took notes in my group while we were talking. So I had the pleasure of chatting with Polly Livermore, who is a longtime nurse at Great Ormond Street in the UK, who is a PhD, and her particular interest is in mental health. So she's surveyed all of the pediatric rheumatology practices in the UK, 15 of them. And 7 of them don't have a psychologist, but I guess that means that 8 do, which is somewhat encouraging. But that overall in the UK, the providers, physicians don't screen, but psychologists will. And Great Ormond Street is lucky to have 2.4 full-time equivalents of psychologists who will see rheumatology patients. Then Lisa from Penn State is a nurse, a clinical care manager, who has 25 years of experience in pediatric rheumatology, and their nurses will go in to see certain patients, the more long-term patients, and they do pre-visit planning and can identify patients who might have some psychosocial needs, but they don't use a particular screener. And then Charlene, who is a nurse in Montreal, she's not the mysterious chopper on your screen, that's Charlene Chopper. She has a similar model as to Lisa in Penn State, that the nurses will go in with certain patients. They also don't use a routine screener, but they will pick out concerns based on their conversations with families, and they have a social worker on their team. And then being the lone physician in the group, I talked about that we also don't have like a screener that we use. We try to ask all of our patients the patient global question, considering all the ways having X disease affects your life, rate how you're doing, 0 very well, 10 very poorly, and have the patient or the family give us a number. And then I usually ask, if you gave me a 5, what's making it a 5? And what would bring you down to a 0? And that almost always brings out some mental health things in addition to physical health things. And that really allows a good entry point for those discussions. And that also helps us get the data we need for our care reforms.
Thank you. So in the interest of time, and I apologize, would the other reporters, facilitators, please type their responses and themes into the chat so we can gather those and report out on them afterwards, but we will have to move on. And thank you so much. I know it was a little bit hectic getting in and out of the groups, but I hope it was worthwhile. And we'll also take your feedback on whether that was useful to you all. Okay, taking a deep breath. Our next presenter, Dr. Kaveh Ardalan, is going to talk about screening tools for depression and anxiety specifically. Dr. Ardalan works at Duke University School of Medicine. He's an assistant professor of pediatrics in the Division of Pediatric Rheumatology, and he co-directs the Duke Cure-JM Center of Excellence in Juvenile Idiopathic inflammatory myopathies. His research focus includes mental health in juvenile myositis, lupus, and other pediatric rheumatology populations, and the influence of psychological stress on cardiovascular health and other health outcomes in juvenile myositis and patient-reported outcomes research. Welcome, Kaveh.
Thanks for the kind introduction and the invitation to speak as well today. So we'll talk briefly about utilizing tools for screening. And this is, of course, a very brief talk. So it's really meant as just the tip of the iceberg. So happy to discuss more during Q&A if you have further questions. So no disclosures, and here's just funding, and just quickly learning objectives to identify why screening is important, learn a little bit about 2 commonly used screeners, and start thinking about what kind of systems and workflow considerations we might need to have. I think someone might have their sound on, so if all could mute, that'd be awesome. All right, so so mental health screening, sort of what is it and why should we be doing it? So the first thing just to know, and this is pediatric wide, is that even before the pandemic, there's been a quite high prevalence of mental health comorbidities or diagnoses in children. So, 1 in 5 adolescents have ever experienced at least one major depressive episode. And since the pandemic in 2021, the AAP, AACAP, and CHA, so Children's Hospital Association, American Academy of Child and Adolescent Psychiatrists, and then the AAP, have actually declared a national state of emergency in children's mental health because of the steep rise in emotional distress and mental health conditions during the pandemic and beyond. We know through quite a bit of work, that Andrea and others have done and presented on today, that there are high rates of mental health comorbidities, particularly in our lupus and other pediatric rheumatic disease populations. To give a recent example, we have an ACR abstract that you can see at this year's meeting suggesting 70% positive screening rate in JDM in a 3-site study that we've been conducting. And one important thing is so why screen though? I mean, we're all sensitive clinicians. We should be able to pick this up ourselves. But it turns out actually in studies, even where patients are very well known to their clinician judgment actually has quite low sensitivity. And that's particularly worse for minority and non-English speaking patients. So if we really just rely on our judgment, as sensitive as we may be, we will actually not pick up many of our patients who have these needs, and we might widen health disparities in particular. And we know that only 2% of pediatric rheumatology practices have incorporated mental health screeners that have been validated. So mental health screening is basically the use of standardized tools to help identify patients who have a high probability of having a mental health diagnosis. There are some screeners that are broadband, so they could screen for multiple conditions. And then there are others that are single condition screeners, maybe just for depression or just for generalized anxiety or things like that. It's important to bear in mind, screeners are not making a diagnosis. They're just helping us identify who could really benefit from further evaluation. And some screeners, but certainly not all, would be able to indicate emotional distress intensity or high risk features. So some screeners are just kind of positive or negative, but others might give you a sense of, how positive. Other thing to know is that suicidality is not necessarily going to be detected by screeners for other things like depression. Often might need to actually do dedicated suicide screening. And so that's important to bear in mind. So this is a sort of simplified flowchart from the publication that's cited below, which has a much more detailed flowchart for how to implement mental health screening in busy clinical practice. But I think a very simple way to think about it is at some point in time, let's say at a clinic visit, you administer a validated screener in the context of a broader psychosocial assessment. And the first thing, of course, depending on the results that you get, is to just make sure, are you dealing with an emergent situation or not? And thankfully, most of our patients are not going to present in imminent crisis, but some might. And so for those, you want to make sure that you have some clear pathway for facilitating referral for emergency services when you do encounter that type of event. But for the majority who thankfully are not in immediate crisis, you want to have defined pathways for what the full outpatient, either urgent or less urgent diagnostic assessment would be. And that could be through primary care, that could be through dedicated mental health specialist referrals. And we probably need to think of other avenues beyond these, but these are at least 2 avenues you can think of based on what has been published by this working group from the AAP. And then once these more detailed assessments, whether emergent or non-emergent, have been conducted, it's really important that a care plan that is truly family-centered be developed and implemented. And then we want there to be reassessment and follow-up, and then rescreening, reassessment over time. So this is a longitudinal process, not just a single point in time. So some commonly used screeners, and there are many out there, but we'll just focus on 2 that are commonly used and well validated, would be the Patient Health Questionnaire 9, modified for adolescents, or PHQ-9A, which is a screener for depression in patients 12 and older. And then general anxiety disorder 7 or GAD-7, which is an anxiety screener, predominantly like generalized anxiety disorder type screener for adolescents 12 and up. What's nice about these is they're brief assessments, so you can implement them in a busy clinical environment, and there's still briefer versions of them. So there's a PHQ-2 and a GAD-2, there's a PHQ-8 that eliminates a suicidality question if you feel that you don't yet have capacity to address those types of really urgent referrals routinely. But you can also have a two-step design where you have these shorter assessments like a PHQ-2 done, and if it flags as positive, reflex to the full PHQ-9. So there's kind of a variety of ways to think about using these measures. And they have strong psychometric properties with good sensitivity and specificity and established score cutoffs that are clinically actionable for sort of mild, moderate, severe, which give you a sense of, how intensely is your patient affected. So here's just for the sake of, for those who may not have seen the PHQ-9A before, here's a screenshot of this questionnaire, and it has questions that really speak to some of the observable as well as subjective experiences of a person who might be dealing with depression, like feeling down, depressed, irritable, hopeless, loss of interest or pleasure, difficulties with falling asleep, changes in appetite, changes in energy, negative self-image, difficulty concentrating or with cognition, and then changes in kind of the level of activation. So speaking or moving more slowly versus being fidgety and restless. The 9th question is important to pay attention to. This is one that, as I mentioned, asks about suicidality. And so again, there is an 8-item version of this if your clinical environment is not yet ready to implement a measure that has this type of question in it. And the response options are here. So not at all, several days, more than half the days, nearly every day. And these are assigned a number of points in parentheses here. And based on the number of points that you add up to get a total score, that helps you know whether or not your patient is screening positive or not. So there are a few unscored items too that you can consider implementing that have to do with kind of past history of depressive symptoms and episodes, impact on function, and then again, getting into recent as well as more remote history of suicidality, suicide attempts. These are all optional. I mean, this is modular, so you can decide if you want to implement this or not. And these items are not actually going to go into the scoring that we will be talking about. So the GAD-7 is, as you can sense, is like a 7-item screener, again, really with questions that have a lot to do with the types of symptoms that we were just talking about, feeling nervous and on edge, worrying kind of about many different things or being unable to control worries, difficulty with relaxing, kind of restlessness and overactivation, irritability and feeling afraid or a sense of doom. And then there is this unscored item at the bottom here about how difficult have these symptoms made your work or your sort of your daily function. And again, the response options are basically the same as the PHQ-9A with points assigned as shown, and you sum the individual item scores to get like a total screener score, and that's what you use to sort of get a sense of if it's positive or negative screening. So how do we interpret the scores? So for both of these measures, the score ranges are the same, which is really helpful. So a score in the range of 0 to 4 means minimal or maybe even no depression or anxiety symptoms. And a commonly sort of prescribed action for this type of score is to still give ongoing psychosocial support and education. Just because someone isn't, struggling or having serious symptoms just this minute, it doesn't mean we don't all need kind of constant care and maintenance of the wellness of our mental state. So that's sort of the action there. For scores in the 5 to 9 range, that indicates mild depression and anxiety symptoms. This could be just, adjustment to a difficult circumstance or maybe an interval stressful event or something. But the actions to take for this would be kind of like education about what depression and anxiety are, sort of anticipatory guidance on if this gets worse, here's how you would know, and here's when you would want to notify us more quickly than your next visit. preventive and supportive care. So if there are like brief interventions or supports that you can provide to, again, address the ongoing symptoms, even if they are in the mild range, that's important. And then reassessment. I mean, this could get worse, right? And so you want to make sure that you capture that. 10 to 14 is when you start to get certainly more concerned, where you've got moderate depression, anxiety symptoms. And at this point, there really should be a push for referral for evidence-based interventions after a thorough diagnostic evaluation by someone who's qualified to diagnose depression, anxiety. These evidence-based interventions could be things like cognitive behavioral therapy, plus or minus pharmacological treatments. And then 15 and up, this is your sort of severe depression, anxiety symptoms. This is a scoring range where you have to feel that this is an urgent referral. It's more time sensitive if someone is this highly symptomatic and they really need initiation or intensification or adjustment of any treatments as well. So just another word on suicidality. So let's say somebody does endorse suicidality on that 9th question of the PHQ-9A, like then what do you do with that? And this is going to be addressed in a subsequent talk, but just as a quick kind of setup for that, you know, there's this Ask Suicide Screening Questions Screener, or ASQ, and it's available for free at the NIMH website. There's actually an integrated PHQ-9 ASQ that's all in one form, so that's pretty awesome. And you basically administer the questions that are shown here, and then I won't go into too much detail, but based on the responses, there's brief suicide safety assessment that you do, depending on which questions people answer yes or no to, and you can kind of stratify the degree of sort of passive versus active suicidal ideation and how imminent the risk to your patient is, so that you know how emergent or versus urgent the referral might be.
1 minute, heads up, sorry.
Okay, yeah, almost done. So this is just kind of recapitulating from a publication in the context of CF, cystic fibrosis mental health screening, kind of an algorithm that sort of summarizes a lot of the screening and actions based on the scores for PHQ-9 and GAD-7. So just an example of, a disease population where this is being promoted as well. And then the last thing is kind of implementing screening. So, I mean, how do you, it's more than just giving questionnaires, right? So there's actually a really nice publication from 2015 in Pediatrics on this. And they basically talk about a number of stages. First, readying your practice. And I think this is most important in some ways. So you need people who are going to champion the implementation of screening. You need to train and retrain staff. You have to create roadmaps so you know when people should get screened, how they should get screened, how results will be communicated to caregivers and providers, and then what actions should follow from different results, and what the emergency situations are and how to deal with those. There are more screeners out there besides PHQ-9 and GAD-7, so selecting your screener and tailoring it to your population is important too. And then the second step is identifying your resources. If you don't have a clear sense of where patients can go, it really calls into question whether you're ready to do actual screening. But once you've got those partnerships and those resources set up, then starting to actually establish your office routines for screening. So how often to screen, whether to do it routinely versus as needed. And I think routine is probably better. Making sure to partner with families, and if they screen positive, identify strengths that the parents and the child have that could help them with recovery or healing. But also keeping a registry or some form of monitoring your positive screens in high-risk patients so that they don't fall through the cracks, and then tracking referrals. So we know that, somewhere in the neighborhood of only 20% of kids who really need treatment ongoing for a mental health condition are actually receiving it. So how can we see who is and who isn't getting the care they need, and keep pushing for those connections to be made? So here's just a few links to some helpful resources if you are interested in screening. And I know I'm over time, so I will wrap up right there.
Thanks, Kaveh. Again, put your questions in the chat. We probably won't even have time to answer a lot of them verbally, but we will keep track of them. And I will send them out to folks so they can respond, and then we'll have a general response time. letter that will go out. So right now I want to reintroduce Dr. Ilana Goldstein-Lieber, who's going to talk about suicide risk assessment in this session. And then in 2 weeks, she'll come back and talk about safety planning. So Kave's touched on it. Go ahead, Ilana.
Hi, everyone. So like Suzanne has mentioned, we're going to be broaching suicide risk assessment. Now, I know this can be an intimidating area for folks, so I do want to reassure you that this can be a clear process.
We lost your
strong.
Okay, you're cutting in and out, Ilana. Your sound is cutting in and out.
Here we go. Can you hear?
Now
I'm
you're
just
good.
going to stop my share for 1 second. Can everyone hear me? I just wanted
Yeah,
to.
we can
Yes.
hear you.
Okay.
Yeah.
All right. That's important. You need to hear me. Okay. So we're just going to plunge right in. Okay. All right. So I have no financial ties to disclose again. So what is the scope of this problem? We're going to start there. So we know that youth and suicide is more common than it should be. We know from CDC data, this is from 2022, that the crude rates per 100,000 children indicate that, well, children and adolescents, young adults from the ages of 15 to 24, we see a 14% rate and 2.8% in 10 to 14-year-olds. So our pre-adolescents are less at risk, but our adolescents are at a considerable risk, thinking about the costs of that. This is for suicide, not suicidal ideation. We know that suicide is the second leading cause of death for persons aged 10 through 34. And that among US high school students for the Youth Risk Behavior Survey in 2019, they found that 16% about had a suicide plan, 19% had seriously contemplated suicide attempts, and 9% had attempted suicide. So pretty staggering rates that we're seeing this, and that was from 2019. So, you know, thinking about our mental health times right now, and we know that this has been a mental health pandemic, that, you know, I would only assume that those rates are more concerning even at present. We know we have limited research on suicidal ideation in Peds Room, but thanks to Dr. Knight and colleagues from 2014, they were able to identify a higher rate of suicidal ideation in a cohort of lupus and mixed connective tissue disease patients as compared to their healthy control peers. And then youth with chronic pain are at an increased risk for suicidal ideation and attempt. And many of our patients across different rheumatic diseases are going to be dealing with chronic pain. So we know that our patients are at risk. I want us to take a step back and talk about definitions, because when we use the word suicide, we need to be all discussing the same terminology. So for suicide, what I'm intending is that it's death caused by injurious behavior with an intent to die. Now, a suicide attempt is a deliberate action or behavior taken to end one's life. Now, this might be interrupted. So someone walks in when a young person is attempting to ingest medication, or it might be that they stop themselves, that they self-interrupt that attempt and they don't proceed and don't move forward upon their own volition and their own sense of what they want to do in that situation. There's also suicidal ideation. So these are the thoughts that we might have about suicide that range from passive to active, with passive being more of a wish to be dead and active being more of an active thought of killing ourselves. And then self-injury. This would be contrasted from that other behavior we talked about as suicidal behavior, where it's behavior with the potential for harm, but without an intent to die. So a common example might be cutting, picking, or it might even be burning oneself, but depends on the patient. Now, I want us to jump into risk and protective factors. What are the things that would be more concerning for a patient in terms of suicide and increase their risk? Especially, what are the modifiable risk factors that we might see? And then the protective factors as well, especially the modifiable protective factors that we can use to help promote their safety. So enduring risk factors, things that aren't going to change most likely, are gender. Now, a gender identity, that certainly can shift, but in general, we find that having a male gender or assigned sex at birth has an increased likelihood of suicide, of a completed suicide. We do see more suicides among females, but among males, we more so see those successful suicides. In terms of age, we see over the age of 13, so just like those stats I showed you, is going to increase your level of risk. Any sort of history of self-injury might be like a gateway to suicidal behavior. And then any history of abuse or family history of suicide or a chronic medical problem. So many of our patients have experienced ACEs in their lifetime, abuse, and then chronic medical problems is also, something that we are going to be seeing every day. And so as you're looking at this list, we have quite a few enduring risk factors that aren't going to change for a patient necessarily. We also have dynamic or modifiable risk factors. So we tend to see with suicide that there is usually a significant stressor or activating negative life event, something bad that happens that triggers that crisis. So it might be an episode of bullying that's particularly intense. It might be an instance of parental divorce that's really hitting a child hard, or a breakup. But there often is a significant stressor that brings on this emotional distress that feels unmanageable, that the patient might get into a crisis state. Other dynamic risk factors, access to lethal means. So I always recommend asking if there's unsecured firearms in the home. It is the easiest way for someone to kill themselves successfully. Substance abuse or command hallucinations. So having hallucinations or auditory hallucinations, commanding oneself to hurt oneself. That's very concerning. In addition to feeling like a burden or hopeless. So feeling like others are being held back by you, or bullying or peer rejection is often a common risk factor. Some things that you want to be tipped off to as well is a high degree of family conflict. This might be something you see and something that might not be present in the visit. Distress related to gender or sexual identity. We see that for our gender diverse youth, that they have a higher incidence of suicide and suicidal ideation. We also know that giving away belongings, saying goodbyes, this might seem obvious, but kids might do this in subtle ways, like just giving a lot of things away. And that might be something that is a tip off that they're having these thoughts. And then increased impulsivity, risk-taking, or emotion dysregulation. So this might look like a depressive episode. This might look like a manic episode where someone is showing excess energy, excess risk-taking type of behaviors. And then sleep difficulties you will also see is a very common problem that we see in our young people and adolescents that we work with, but it's also something that we want to note is going to increase emotion dysregulation and put them more at risk. Now, what are the protective factors, the things that we can enhance and promote? So reasons for living and future goals. You can prompt a really healthy discussion with a patient to really help them conjure up what are those things that orient you towards the future and make you motivated towards what's happening next. If they're willing to create a safety plan, if they're willing to say yes to that question, like, are you wanting to keep yourself safe? Caregiver availability to reliably support the safety plan, to make sure that the firearms are secured, that other lethal means are secured in the home, and that they're able to consistently maintain that, as well as just family support. We know that's so important for our young people to have supportive people at home, in addition to coping skills and mental health care, which we know is we're in such a difficult situation with the mental health crisis, with having less of those supports, but that's protective. If we can link someone with that support, or if they have it already, that's also something that I would see as more of a factor that makes me feel more confident in their ability to cope if they have that regular therapy session scheduled for next week. All right, so now we're going to dive into evidence-based suicide risk assessment. How do you do this and implement this? Now, Kaveh mentioned some of the suicide risk assessment in his presentation. And so we're going to dive into two measures today, the ASQ, the Ask Suicide Screening Questions, and then the Columbia, which is a suicide severity rating scale. These are both psychometrically sound and evidence-based assessments. So the ASQ, and I'll just keep it abbreviated, it's nice and clean and neat, is a 4-item suicide screening tool. It is very short, it is 20 seconds. So you can administer this just right side along your PHQ-9 and your GAD-7. It takes 20 seconds for the patient to complete from ages 10 to 21, and it's applicable for our setting. So it's appropriate to be used in a specialty clinic setting. This is used, I know, in our Nationwide Children's Hospital primary care as a standard of care. You can do it in print form on an iPad, or you can ask the questions yourself. I ask this in, I can't tell you how many times a day, and I just know the questions by heart by this point. There's even neat cards you can get with the questions. Here is the tool. So this is
warning. So sorry, 2 minutes.
Minutes. Oh goodness. Yeah. So the ASQ consists of these 4 questions, starting with, in the past few weeks, have you wished you were dead? Have you felt that your family or you would be better off? And in the past week, have you had thoughts about killing yourself? And finally, have you ever tried to kill yourself? If any of those are positive, that is going to, at the very least, be a non-acute positive. But if you answer positive to the, are you having thoughts of killing yourself right now, the 5th question, which is an additional question, you only answer that if you get a positive on the first 4 questions, then you're considered an acute positive, or the patient is acutely positive for suicidal thoughts. Now, when it comes to the ASQ, they provide a clinical pathway or a step-by-step directive of what you can do next to address that positive, but essentially you're going to be screening more completely. They recommend using the brief suicide safety assessment, which is listed here, but we're going to defer from that today because they don't give as much clear guidance for clinicians on what constitutes a certain level of risk. And I want for all of y'all to feel like you know exactly what this patient in front of you, their risk level would be in the situation. So we're going to defer to the Columbia, which is really supported for a comprehensive suicide assessment. Now, this is the Columbia, but it's an adaptation of it, the safety protocol. And the nice part about the safety protocol is we have this lovely color coding. And that's for a reason. So it starts out by asking suicidal ideation severity, starting with passive suicidal thoughts, a wish to be dead, moving towards current suicidal thoughts, have you actually had any thoughts of killing yourself? And then moving towards having a method that you've considered to kill yourself, having an intent to kill yourself without a specific plan, and finally having an intent with a plan to kill yourself. Now, if someone is at number 4 or number 5 in the past month, they're going to be high risk. That's going to constitute a high risk where they need to be evaluated emergently by a mental health professional. If they are exhibiting number 3, that's moderate risk. And then yellow would be that mild risk. We're also going to ask about suicidal behavior, and they have some really clear questions that you can ask patients and examples of what might be a suicidal behavior so that you know just what to prompt your patient with. And again, if there's been suicidal behavior in the past 3 months, high risk. They also ask about some of these risk and protective factors. So we just went over them. We don't need to go into them in more detail, but this just gives you a sense of if someone has a lot of things loading on the top of this screen, those risk factors, they could likely even move from low risk to moderate risk based on having that many risk factors. Now, I'm going to show you a whole risk stratification system that they give you for this, so just stay tuned. They also ask you about the suicidal ideation intensity, how often these thoughts happen, can you control them? But this is not going to be as clearly used and linked to your risk level, but it's helpful information to know for this patient. You also will ask about suicide attempts and self-injurious behavior specifically. But again, we've already asked about that above, so we have a clear delineation of risk. Finally, this is the determination of risk level. So high risk would be those patients with suicidal ideation with intent, so an intent to kill themselves, or an intent with a plan. And this would be in the past month. So if they've had this 5 months ago, that wouldn't necessarily qualify them as high risk, but we're thinking in the past month. But if they had suicidal behavior within the past 3 months, let's say they attempted last month or 2 months ago, and they haven't seen someone for that or been safety planned, then that would be a high risk where you would want them to initiate a mental health evaluation in the emergency room. Moderate risk would be suicidal ideation with consideration of methods without a plan, intent, or behavior in the past month, as we noted before, or having multiple risk factors and few protective factors, or suicidal behavior more than 3 months ago. You'll have all this information based on your initial assessment where you got that information. So this is just about plugging it in to that formula of what you were provided with by the patient. And then finally, low risk, which is a wish to die or suicidal thoughts.
So sorry to interrupt. We're at time.
Oh, of course.
I
Okay.
mean, we gave you the impossible task of explaining suicide. assessment
I know. I apologize, y'all.
We apologize.
I just
We
wanted to
have
echo.
more time.
I just wanted to echo crisis resources that are listed up here, and the slides will be available to you, and that you can call 911 if an escort is needed. So if a patient is saying that they have a plan to jump out of a car, then I would call and get an escort to make sure that they're safe and that the parent is able to get them to the hospital. But that was all, y'all.
Thank you so much.
Thank you.
Of course.
Susan, back to you. We're just going to wrap up. Everyone, we're
Right. So we just have one last slide for you all to look at. Please remember to fill out your evaluation form for medical education credit purposes. Please remember that the second session, which I think will be very helpful in terms of looking at safety planning for suicidality, looking at some of the other possible resources for mental health support that you may not have thought of, will be coming up in 2 weeks. If you have any questions, please contact me. This is the last this is my email here. And also, if you need more information about the CureJM Foundation Juvenile Myositis, you can find that at our website. We have a lot of mental health resources that I've put on the website. So escaping here, thank you. And I would just like to turn it over to Tala for the very last wrap up. Thank you so much.
So a few take home points. We learned that mental health problems are prevalent and they impact different health outcomes. We walk away today with important tools of communication, of move soft approach and how to carry out a conversation about mental health with patients' families. We learned about different signs and symptoms of anxiety and depression to watch out for, and what are the different screening tools available, and as well as the suicide risk assessment. And this is a nice segue to our next workshop where we'll learn how to perform safety planning and how to apply all of this really in clinic, kind of go through the logistics a little bit, and the different types of mental health interventions, including coping, CBT, art therapy, all these different exciting things. So I'd like to thank the speakers, and we really hope that you enjoy this workshop and hope you take away what you learned from here today and spread it within your circles. I'm looking forward to seeing all of you the next workshop. So that's October 27th, don't forget.
Thank you, everybody, for being here. I really appreciate all of our presenters. If you have any questions about medical education credits, stay on the line for a second and I'll get Matt back here and we can do texting and talking, etc. So thank you so much. I know everybody's on different time zones. And
thank you to the speakers as well.
Yes, I did. I said thank you to all the presenters. Yeah, including you, Tala. Thank you.
Oh, thanks.
Yeah.
Bye, everyone.